You know, early in the pandemic, we heard that hospitals were competing for ventilators, COVID-19 tests, personal protective equipment. Well, now sites across the country are competing for nurses. The fall surge in COVID-19 cases has turned hospital staffing into a sort of national bidding war, and some hospitals are paying exorbitant wages. Now, that causes a whole new set of problems. Dave Johnson is a national thought leader on healthcare and is the author of 2 best-selling books, Market versus Medicine and The Customer Revolution in Healthcare. And Dave joins Willie and me on the phone today. Dave, thank you for joining us.
Well, good morning, Jennifer. Good morning, Willie. Great to be with you.
Good morning.
So tell us when and where this bidding war for nurses started. Which parts of the country?
Well, it started with the spread of COVID-19. So initially, when the outbreak was in the East Coast, we saw a real need for respiratory therapists, critical care nurses, others that would deal with COVID. And then as it then moved from the East to the Midwest and then out West. But now the problem is we've got record hospitalizations, record deaths. So this challenge is everywhere in the country right now, and it's particularly afflicting rural areas. So it's much harder. For example, in New York, many Good Samaritans moved to New York temporarily to help with the surge in patients, and that just can't happen right now because the virus and COVID-19 is everywhere.
Why, in your opinion, is because we keep on hearing that we need more nurses, we need more beds, we need more rooms. Adults are being put in children's hospitals. Why don't you think the message is getting across? Is it because maybe that there is a privacy, HIPAA laws that we can't see what's going on, but just news just won't get across from everyone who's out here listening?
Well, I think the challenge, Willie, is more just basic supply and demand, the way Jennifer was outlining in her earlier comments. Initially, we thought the issue was beds and ventilators and equipment, but it turned out that the critical resource is people. And when you've got hospital volumes at record levels, essentially everywhere in the country, we're just not staffed as a country to do this. So it's each individual institution is sort of catch as catch can, and we do administer healthcare regionally and by institutions. So it's really each one is in it for themselves. There isn't some overarching body saying you've got to shift resources from here to there to meet the crux. So as I mentioned earlier, some of the worst hit places for the nursing shortages, healthcare professional shortages, are in rural areas that just aren't as attractive for a whole host of reasons in their ability to attract professionals. So it's more just the byproduct of an unprecedented crunch in demand across the country all at once.
Dave, I know that hospitals have long relied on traveling nurses. I've met many of them to fill gaps in staffing. Then they don't have to commit to hiring them long term. But there's a trickle-down effect, right? I mean, how does this affect the average person?
Well, your point about health systems using traveling nurses, agency nurses, temporary nurses is true. In fact, in many ways, it's very smart. They staff to an efficient level and will use overtime to deal with the surge. And to the extent they even go beyond that, they go to temporary. And that works well in normal circumstances. And so good for them. And also the job of these temporary professionals is pretty hard. You can imagine that each organization has a specific way of doing things, their own protocols. So a traveling professional needs to come in and adapt to that organization. So in terms of answering your trickle-down effect, I think there's always going to be some friction that occurs as new people come in, no matter how experienced they are, to a culture, and that ultimately works its way into patient care. You got to believe that that's straining care delivery protocols and models, at least in some hospitals around the country right now, as they adapt to both the shortage and training new people to come in and address it.
Assuming the dust will settle one day or we learn to coexist with COVID-19, Will the healthcare system ever get a chance to adjust to what we've seen in the past year?
I hope so. We
Be realistic. It's okay.
No. I hope so. Actually, the good news, and it's really, really good news on the vaccine front, is the development of these vaccines. And we've heard most about the Pfizer and the Moderna vaccines, but there are 400 vaccines under development right now globally, and they're using entirely new technology. The messenger RNA, which is the basis for the Moderna and the Pfizer vaccine, is almost like software and computer design. It's tailored specifically, and you've heard the success rates are in the 95% range, and those that do get COVID with the disease are it's a much less virulent case. So I think from a public health perspective, we've underinvested, but we now know the importance of public health. And we now have tools in these new ways of doing vaccines that can come to market much faster. Now, in the event that we end up in the situation we're in now and we're not able to control virus spread and we get a full-on outbreak, I think we're going to have to think long and hard about how we flex staffing. I think the physical part of this is easier. So it's a little bit like COVID, and it's a little bit like Pearl Harbor in World War II. I think of COVID as healthcare's Pearl Harbor. So we got to go back to the studs and rethink the public health aspect of this, as I was saying, but also how we address pandemic level disease spread more effectively than we've been able to do it this time, because we've been making it up as we've been going along.
Right. And Dave, here's something that I was reading. I know you read this too. Back in March, a nurse named Claire Treppenny was working at St. Anthony Hospital in Lakewood, Colorado, and she loved it.
Yeah.
She was taking home $800 a week, and her employers were telling her she was caring for 6 patients. They patched their protective gear with tape, and the employers kind of told the nurses to suck it up. So this particular nurse packed her bags, became a traveling nurse. She got a 2-month contract in New Jersey, which was a hot spot then, and she was making $5,200 a week with a contract that required adequate protective gear. And then fast forward a couple of months, in Sioux Falls, South Dakota, nurses can make more than $6,200 a week. A recent posting for a job in Fargo, North Dakota, offered more than $8,000 a week. And some nurses, according to this article, can make as much as $10,000 a week.
Yeah, supply and demand. That's what I was talking about with Willie earlier. And where you are in Missouri, there are postings for $5,000 a week. I mean, that's not unusual. So that's, order of magnitude 5 times. If we annualize that salary, 5 times what a nurse could make in a permanent job. And we are asking an awful lot of these people. They're exhausted. So to some extent, good for the temporary nurses that are willing to travel.
Oh, they deserve it.
Yeah. So, but overall, it's very tough on the hospitals because they operate with pretty tight margins anyway. And so this is added cost. The government's mitigated a little bit with some of their emergency relief, probably more of that coming. But yeah, it's we're working our way through this. Hopefully we're seeing the light at the end of the tunnel, but we've still got at least a couple of more months before we see measurable improvement. So.
Yeah, they're bringing on nurses here, hospital staff. I mean, what kind of shortage do you think? By 100 ballpark? I mean, what do you think they're short by if you had to, let's say, like an area like St. Louis?
I can't comment specifically on St. Louis. I just don't know the details. But my sense is that the staffing pressures are in sort of the 20-25% range. Okay. So and so you can make up some of that through overtime and so on. But your point about the frontline professionals being burned out, you see it all over the place. They've given as much as they can give. So we're addressing that as well. So there isn't as much flex in the current workforce as there usually is, and then we're having to bring in other people on top of that. And obviously, and we saw this in New York, is when the system breaks down, then people start dying in their homes and not being able to get in and so on. But again, good news here is we've gotten better at treating the disease. The bad news is there are just a lot more people needing the treatment.
Well, Dave Johnson is considered a national thought leader on healthcare, and he's the author of 2 best-selling books, Market versus Medicine, America's Epic Fight for Better Affordable Healthcare, and The Customer Revolution in Healthcare, Delivering Kinder, Smarter, Affordable Care for All. Dave, thank you so much for joining Willie and me here in St. Louis. We appreciate it.
Yeah, it's been my pleasure and very thoughtful discussion. Thank you.